A very good morning to one and all. On behalf of the management of Bangalore Institute of Dental Sciences and its faculty, our beloved principal, ma'am, Dr. Demystified, and our speaker, Dr. Abijit Gune, sir, the IOS office bearers, and the BOSG conveyors, I welcome all of you today to our webinar on TMD Demystified and Ortho Perspective. We'll begin today's program by invoking the blessings of the Almighty. I request our beloved ma'am to welcome the gathering.
Good morning to one and all. On behalf of the Department of Orthodontics and Dentofacial Orthopedics, Bangalore Institute of Dental Sciences Hospital and Postgraduate Research Center, I take great privilege in welcoming our respected chairman, Shri Katuri Subbarao sir, and express my sincere gratitude to him for always supporting us and having the full faith and encouragement in all our activities. It gives me great pleasure to welcome our pillars of strength, our directors, Dr. Siri Krishna and Dr. Swaira Rao, and thank both of them for always standing by us at every step of our activity at BIDS. My respectful welcome to our very hardworking and enthusiastic President of the Indian Orthodontic Society, Dr. Silju Matthew. Thank you so much, Dr. Silju, for your advice and support in all our endeavors. I welcome our ever-smiling and energetic Honorary Secretary, Dr. Sridevi Padmanabhan, Madam. Thank you, ma'am, for always being so very prompt to all our SOS calls, and we really take great pleasure in thanking you as a team for all your support through this webinar. I extend a very warm welcome to our President-elect, Dr. Shri Krishna Chalasani, and our Vice President, Dr. Surya Kant Das, and thank them for joining us today. With a deep sense of gratitude, I welcome one of the legends in our specialty of orthodontics, Dr. V.P. Jayade sir, who has kindly consented to be a panelist for today, and profusely thank him for the same. A very warm welcome to all the office bearers of the Indian Orthodontic Society, all the EC members of the IOS, and to our very own BOSG conveners, Dr. Anup Belludi and Dr. Santosh. I also welcome all the heads of the departments, faculty, and all the senior orthodontists and student members of the prestigious Indian Orthodontic Society who are participating in today's webinar despite the fact that it's a very busy weekday. And I hope that their thirst for knowledge will be well rewarded at the end of this webinar. I now consider it my privilege to welcome and introduce our guest speaker for the day, Dr. Abijit Gune. Dr. Abijit has completed his Masters in Orthodontics from the prestigious SDM College of Dental Sciences, Dharwad in the year 2001. He completed his DNB in orthodontics in 2003. He was an adjunct faculty at the University of Pacific between 2007 and 2008. He then went ahead and completed an ADA-sponsored evidence-based dentistry training in 2008. He has to his credit a mini residency in orofacial pain and TMD management from the University of Lexington, Kentucky in 2014, and a mini residency in dental sleep medicine at the University of Pacific, San Francisco in 2017. He completed his fellowship in lingual orthodontics at the University of Texas in 2019 and is also a board member at the American Lingual Orthodontics Association. Thank you, Dr. Abijit, for accepting our invitation and taking time out of your busy practice to enlighten all of us today on the topic of TMD from an orthodontic perspective. I request all the participants, before I hand over the mic to Dr. Abijit, to kindly put in any questions that you have for the speaker in the chat box so that we could take these questions at the end of the webinar so that it can be answered. Thank you so much, Dr. Abijit. you may kindly take over, please. Thank you.
Thank you, madam. Thank you very much for the opportunity. And in the presence of all our stalwarts, I definitely feel very honored that all of you have taken some time to spend a few minutes with me this morning. Good morning to all the participants. And without further ado, let me share my screen. In case there is any issues with the internet connection, please pardon me for that. I hope that Dr. Manju will inform me via WhatsApp, and that way we can fix the problem. So again, thank you very much. I wanted to take this opportunity to present what I have learned and what I have faced in my own clinical practice. At the outset, I would like to let everyone know that I am not in full-time academics, and neither am I in big-time research, but I'm just a private clinical practitioner who faces on a daily basis patients who come to us with TMJ problems. I had the opportunity to learn the TMJ at University of Kentucky, the management of TMDs, and I just felt like I could share this with all the members and any orthodontists who were interested in learning more about it. So at the outset, again, thank you to the Indian Orthodontic Society as well as to the Bangalore Institute of Dental Sciences for giving me this chance. I know Dr. Jayade is listening to this presentation, and I hope I make him proud at the end of this lecture. But my career begins and ends with Dr. Jayade's blessings always. So without further ado, I'd like to proceed. This is a photograph with Dr. Okeson at University of Kentucky. If any one of you has the opportunity to visit the United States for any kind of studies, I would say if you are able to spend about a week or 10 days, please do find time to visit the University of Kentucky at Lexington. Dr. Okeson runs a phenomenal TMJ center there, and there's a lot to learn from this professor. As you know, our life always revolves around teeth. Day in, day out, we speak about teeth with our colleagues and at times even with our family members. As orthodontists, we mainly focus our time around the periodontal ligament, but today we are going to focus a little bit about the TMJ. And as we know, there is nothing more fundamental to treating patients than actually knowing the anatomy. So I know this is very basics, but I'm just going to run through a few slides. There, I was informed that there might be some PG residents as well. So bear with me if this is too basics, and we will slowly proceed into the TMJ diagnosis. So we deal with teeth and PDL all the time, but today we're going to talk about the condyles and the articular surfaces and its relationship to the mandibular fossa that forms the bony structures of the TM joint. We treating TMJ patients, we often have to focus upon the relationship of the condyle with the articular disc. And to my recollection, during the dental education as well as during postgraduate education, I did not find myself spending too much time learning about the TMJ. So I found it very fascinating to have a chance to attend a mini residency. So our condyles usually in a normal healthy patient should lay in the center of our articular disc. The articular disc, is thicker, has a thicker anterior band and a thicker posterior band. And in the normal relationship, our condyle rests in a very thin intermediate zone. This is a view of the cadaver. And as you can see, the condyle again is resting in a posterior superior fashion, right in the middle of the intermediate zone. And the structure above that is labeled the disc has a strong anterior border and a strong posterior border. The anterior section of that disc, you can see, is attached to some muscle fibers, and we will learn in the slides ahead. The attachment comes from the superior head of the lateral pterygoid muscle. So this is a graphic representation of the same disc and the condyle relationship. What is labeled in the back here called the RT is a retrodiscal tissue, and that comes into play in TMJ patients who are experiencing a lot of pain. This is a frontal view or the anterior view. We have the medial pole of the condyle and the lateral pole of the condyle, labeled on the left-hand side as the MP and the LP. And the right figure is again the cadaver section showing the normal relationship of that condyle to the fossa with the articular disc in the middle. This is a video.
This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle. During opening, there is rotation in the lower compartment and more of translation in the upper compartment.
I just wanted to share this video courtesy of Dr. Westerson and Dr. Erickson, who have done a phenomenal amount of studies on TMJ. But this cadaver dissection basically shows the normal movement of our jaw joint. Let me play that movie one more time just for everyone to absorb that.
This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle. During opening, there is rotation in the lower compartment and more of translation in the upper compartment.
So that's our normal jaw movement. The movement of our jaw joint happens on a daily basis during various functions, and the smooth rotation of the condyle and the smooth translation of the condyle during these jaw movements will lead to a pain-free jaw movement throughout our life. The muscles that are involved around the function of the TMJ, we saw a diagram that shows the superior belly of the lateral pterygoid muscle, but there are other masticatory muscles that play an important role in the health and function of the jaw joint. We have our temporalis muscle, the masseter muscle, which are the strong closing muscles of the jaw, as well as the medial pterygoid, which is an elevator, and a lateral pterygoid muscle that is primarily involved in the translation of the jaw forwards. This is normal functioning of the muscles. You can see the various muscles firing during the opening and the closing of the jaw movement. The masseter muscle, as we know, has a superior portion and a deep portion, and both of those portions of the jaw muscle are strong elevators responsible for closing of the jaw. The temporalis, as we know, has an anterior belly, a middle portion, and a posterior portion. Again, the main function is elevation of the mandible. The medial pterygoid, which is on the inside of the mandible, has a function of elevation, whereas the lateral pterygoid muscle, which has the two bellies, has the important function of protrusion of the mandible. The digastric muscle is a depression of the mandible, which causes the opening of the jaw movement. And there are other various head and neck muscles that play an important role in stabilization of the TM joint. The fine coordination of all of these muscles is what keeps us pain-free throughout our life. And this muscle system is best illustrated in this diagram as an elastic band. And if one elastic band fails, you can imagine that the balance of our head-neck structures will be off. So the mechanics of the mandibular movement, we use our mouth a lot during the day for various functions, and the use and abuse can definitely be neglected. Here again is our normal opening and closing. On the right side, you can see how the disc is kind of pulled forwards by the superior belly of the lateral pterygoid muscle. As the condyle moves forwards during translation, the retrodiscal tissue shown in the yellow is kind of engorged. And when the teeth come back into contact, we find that the tissue relaxes back into its normal anatomy. The initial part of our jaw opening happens within the superior cavity of the TMJ, and that is involved only with the rotation of the jaw. During the rotation movement, we find ourselves opening to only about 20 to 25 millimeters, followed by the translation, where you can see that the condyle has now moved slightly over the disc, and the disc is now moving over the articular surface. At that point, the rotational movement then moves into a translation movement, and we can open to about 50 millimeters of jaw movement on a normal, healthy individual. This is illustration showing again just the A to B is a rotation movement where the condyles are still within the articular fossa, and in the translation movement, the condyles are then moved downwards and forwards. So this is all pure normal anatomy. What are the criteria for optimal function? One of the main functions we talk about in dentistry is centric relation. And there have been many definitions of centric relation over the years, but one definition I'd like to borrow from the Prosthodontic Society is where they stress upon the anterior and superior position of the condyle against the articular eminence. So these, when the mandible is closed, we have these three surfaces in contact. The two condyles that are touching the articular surfaces via the disc, and of course our posterior teeth that come in contact. When the elevator muscles are closing the mandible, as you can see on the left-hand side, the condyle is directed anterior-superiorly against the disc into the articular surface of the mandibular fossa. This is the cadaver section. Again, the condyle is shown resting on the thick posterior border of that disc, and the disc itself is resting against the articular eminence. That is referred to as a musculo-skeletally stable position, which is one of the most important concepts in treating TMJ patients. If we can identify the musculo-skeletally stable position for the patient, then most times we are able to relieve their painful situations and often correct the position of the disc-condyle relationship. As we know in orthodontics, we often see a lot of class 2 malocclusions. In a typical class 2 malocclusion, we might face a situation where the mandible is driven posteriorly and hence is away from that musculo-skeletally stable position, and it's not resting over the posterior border of that articular disc. If forward translation from in a class 3 malocclusion might be the reverse, where the disc is posteriorly displaced and the condyle is brought down furthermore over the articular eminence. So these are some normal variations that we might see in our patients who have different types of malocclusions. We know that the TMD, the temporomandibular disorders, do not originate from a single factor. As opposed to that, we have a multifactorial etiology for their functional disturbances. And any of these masticatory systems, if you have a functional overload, then the patient is going to feel various different symptoms. It could be as simple as a tooth wear, or it could lead to a TMJ pain. In between that, often the patients might go report to their dentist with pulpitis or tooth mobility. They may report to the dentist that they have jaw muscle pain, or very frequently, like we often hear, is the complaints of clicking and popping of the jaw joint. The last but not the least, headache is often associated with some TMJ discomfort, but that alone cannot be attributed to a TMJ. Headache is again a very big and vast topic, and there are many medical professionals that we can lean on in case a headache cannot be from a simple diagnosis of a TMJ condition. So these are the 5 main etiologic factors for TMD, for temporomandibular disorders. One is an occlusal factor, which we always deal with as dentists. Second is trauma. It could be an accident that the patient finds himself or herself in. It could be emotional stress. We find a lot of patients complain of clenching and grinding their teeth during stressful situation. It could be some deep pain input that is more centrally mediated, that we have um, no way to diagnose in a very simple fashion. But it also could just be parafunction from nighttime grinding, primarily derived from sleep apnea. However, if any of these etiologic factors are present and the patient has a good adaptability, then that particular patient might still be unaffected and may never have a TMD sign or symptom that they report throughout their life. The same 5 factors, if one of those factors is off, and it could be as simple as the dentist has placed a new crown, the crown needs some adjustment, but during that ensuing 7-day period, the patient cannot handle that a new occlusal factor. And if the patient has poor adaptability, then that patient is more susceptible to develop TMJ symptoms. And that adaptability of the individual could be because of genetic factors, it could be biologic factors, could be hormonal factors, or could be emotional factors as well. If that patient presents with poor adaptability over a long time, and now reports back to the dentist, and the dentist now, for example, replaces a crown, then the patient's symptoms are not going to be reduced. And oftentimes it happens because of time factor. If the patient is reported back fairly quickly, then we are able to hopefully treat those symptoms and relieve the underlying TMD symptoms as well. So what are the signs and symptoms of a temporomandibular disorder? The most common one that they report to us as dentists, and in the United States, they have found about 15 to 20% of patients report to their dentist with clicking and popping. And that's a big percentage of population that comes to us asking for help. And I found myself many times not realizing what the diagnosis could be in these situations. And without a proper diagnosis, we all know we cannot treat. So anytime a patient reports to us with any signs and symptoms of TMD, they could be divided more or less in 3 categories. One is that affects the muscles of the TMJ system. Second, it affects the actual jaw joint itself. And third, it could be the symptoms affecting the dentition. Like we saw, it could be pulpitis, it could be tooth mobility, or it could be tooth wear. So let's take a look at the systems, the functional disorders of the muscles themselves. Sometimes you may all have noticed that the patient reports to you in the middle of orthodontic treatment, and they are either reporting to you of severe jaw muscle pain, and they are pointing towards their masseter muscle, or at times we've had patients report to us with a decrease in the range of motion, which typically the patient notices when they're not able to open their mouth as wide as they used to. These muscle disorders can be, again, reclassified into various different categories, but the 2 main ones that we not often find in dental practices is what we would refer to as the local muscle soreness, which is the non-inflammatory myalgia. And second is the myofascial pain, which often has a trigger point that the patient might point to. So I wouldn't go in details of the other ones. Let's move forwards to learning about the disorders of the TM joint itself. So within the TM joint, we often have patients report to us. These may not be orthodontic patients, but I do see a fair number of patients who come to us seeking help for TMJ pain. And this pain or arthralgia could be originating within the discal ligament, which is the articulated disc itself, or the capsular ligament, or most often it is originating from the retrodiscal tissue, which has the highest number of the nerve endings, as well as is a venous pool. This arthralgia pain is often very sharp, it is sudden, and it is intensely associated with joint movements. So we see patients with pain in our practice, and the second category of patients we see is the dysfunction. And the dysfunction is the most interesting for us as dentists because a lot of times it is very perplexing. And that is when these joints produce various sounds. So we learned the normal relationship of the disc and the condyle in the previous slide. But this is when the jaw is actually functioning. So if you bring your attention to the slide and where it is labeled number 1, that is the normal relationship when the teeth are in contact. And then follow the slide to the right, and it goes along a clockwise rotation. So you will notice that as we open the jaw joint, as we open our mouth, the condyle moves over the disc into a intermediate zone, and then the disc translates forwards along the articular surface. And we looked at this video before.
This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position.
So I'll move forwards since we've already watched this video before.
The disc is consistently lying in between.
Now, when we have a functional dislocation of the disc, this slide represents what happens in a functional dislocation, commonly referred to as a disc displacement. In slide A, it is showing the patient having a disc displacement when the teeth are in contact, and the slide B is showing where the disc is completely off of the condyle and the patient is still resting his teeth or biting down. The diagram C is a cadaver representation of what happens to the disc. It is completely away from the head of the condyle, and it is more located along the articular eminence. So this diagram represents what happens to the disc as the patient tries to open his or her mouth. The condyle now, if you follow the diagram from the topmost 12 o'clock position to the 3 o'clock position slide, you will notice how the condyle is trying to translate forwards over the articular eminence, but the disc in the initial stages is preventing the condyle to get over onto the intermediate zone. At some point, the patient can override that and then bring their condyle in figure 4. You can notice that the condyle is now over that intermediate zone. And the transition between 3 and 4 is when the patient will hear that first click. This disc is displaced anteriorly, but by manipulation of their jaw, the patients can bring the disc back over their condyle. This condition is called the functional disc displacement with reduction. As the patient, if you follow the diagram from slide 5 there, back to number 1, now the patient is closing his or her mouth, and as the patient closes, the disc to a certain point follows back over the condyle, and as soon as the patient bites down on his back teeth, now we go back to slide view 1, where the disc is displaced away from the condyle. And this cycle continues throughout their day, where as the patient opens and closes, especially when they're chewing their meals, they will hear this loud clicking or popping of the disc condyle relationship. And that becomes annoying It may or may not be associated with pain, but sometimes the patients will want to report to their dentist to seek some help. So the next slide will show us the video of what happens in a functional disc displacement with reduction.
In this joint, the disc is anteriorly displaced and it's reduced on opening with a click. These joints demonstrate reciprocal clicking, which implies clicking during opening, followed by clicking during closing. The disc is here again anteriorly displaced. The configuration of the joint compartments corresponds very well to what has been seen on arthrograms and to observations during surgery.
So you can appreciate in this video how the disc is constantly displaced anteriorly, but the patient can still recapture the disc as they open to a certain point. And then beyond that point, the disc will stay over the condyle. Most times the patients will not report of any pain with this particular disc displacement. So in this slide, now what we are looking at is a more severe disc displacement, where now the disc morphology has changed and the condyle is resting much more posteriorly over the retrodiscal tissue. In these situations, usually start or happen due to the chronic nature of the disc displacement. If the patients have not received any treatments and they ignore the initial clicking or popping sounds, then the disc over a period of time becomes more and more collapsed and is displaced almost permanently in a more anterior direction. This condition now becomes referred to as disc displacement without reduction. And I think we have a video to watch, but here is the diagrammatic representation. Again, slide 1 shows that the disc is already anteriorly displaced, and as the patient tries to open within the superior compartment of the jaw joint, the condyle is rotating, so the patient can open to about 20 to 25 millimeters. However, to be able to open wider than 25 millimeters, the condyle has to get over the disc, and then the disc condyle has to translate over the articular eminence. In this particular slide, because the disc morphology has changed, the condyle is not able to get over the disc. The patient cannot open their mouth more than 25 millimeters, and they do not hear a click at all. When they close their mouth, the disc is still displaced anteriorly. The patient reports of pain in most circumstances. This is called disc dislocation without reduction. And the classic sign for this condition is the patient usually cannot open beyond 25 millimeters approximately.
The next joint demonstrates anterior disc displacement without reduction, which implies that the disc is consistently lying anterior to the condyle. During all mandibular movements, the disc is lying anterior to the condyle, and at maximum opening, the disc is folding downwards as seen here.
So in this condition, you can see that the condyle is never able to get over the disc and for the patient to be able to open their mouth normally. This condition, like I mentioned, is often associated with painful episodes, and the patient definitely will report to the dentist to look for a solution. The third condition, I should say, that we normally see in our practices is a condition called subluxation. This condition often is the patients are very worried about this condition because they can actually feel the condyle popping out of the jaw joint in front of their ear. And they feel that that is the clicking sound that they're experiencing. However, there is a little difference between the clicking and the subluxation. And the subluxation is a variation in the anatomy of the articular eminence. In this condition, the patient can open fairly wide, and sometimes they open beyond the normal range of motion. The sound that the patients hear that they call the click, it can be differentiated from a click, and it appears more like a thud. So I think we have a video to watch, and you will notice the difference in the condition for this patient who has a subluxation. I hope you can see my cursor where I'm pointing, and right in front of their ear, you can feel the condyle almost popping out. And the patients observe themselves in the mirror, or they can feel the condyle popping, and they feel that this is the clicking condition that they have heard from other friends or family members. However, this patient, as you can see, can open fairly wide, and this is not a disc displacement click sound, but this is more of a subluxation. And then a lot of times we have seen this condition in dental schools that we call the spontaneous dislocation, where the mandible, the patient cannot close their mouth. And usually we know how to reduce those spontaneous dislocations, also called as the open lock conditions. In these open lock conditions, the disc is usually displaced posteriorly. And as you can see in the bottom diagram, the condyle slides anterior to the articular eminence, and eventually the patient cannot close their mouth. So this condition is also very scary for the patient, and definitely much more scarier for the dentist if he or she has seen this condition for the first time. Luckily, our professors have always taught us on how to reduce these conditions and assure the patient that this is not as serious as they think. And we often tell the patients to control the range of their mouth opening. The other inflammatory conditions that patients report to us usually are synovitis, capsulitis, which usually are painful, but the most painful of them that I highlighted at the bottom is the retrodiscitis. And this condition is definitely something to be learning about as our dentists and orthodontists, because this can happen to us as orthodontists, where patients get referred to us by their dentist because the patient has developed an acute malocclusion. The patient reports to the dentist and says, I'm not sure what happened, but my back teeth are not coming together. They do not contact each other. And that's how we start seeing these patients. And our first glance as orthodontists might be, oh, definitely there is a posterior open bite. But if you're not aware of the TMJ conditions, then we might mistake that for a true open bite as opposed to a transient open bite caused by retrodiscitis. So as we saw in the diagrams, the condyles are supposed to rest on the thick posterior border of the articular disc. And if the disc is dislocated anteriorly, now the condyle is resting on the retrodiscal tissue, which is the highly vascularized tissue. And a constant trauma to that retrodiscal tissue causes inflammation of that vascular tissue, which causes swelling within the joint capsule. And as the swelling sets in, it pushes the condyle forwards, causing the posterior open bite. So this condition, retrodiscitis, is very easy to treat. And if we have not diagnosed it correctly, we might lead the patient to a wrong treatment plan. The last but not the least is the severe-most condition in TMJ, which is the osteoarthritis or the degenerative joint disease. This usually is a result of bony destruction of the condyle itself. There is a lot of resorption of the condyle, sometimes resorption of the mandibular fossa as well. And that is primarily due to the increased loading of the condyle and the disc complex. These conditions, the osteoarthritis, patients report to us with pain, but the classic sign that you're looking for is the patient will mention that he or she hears grating sounds within the jaw joint. So the patient will not say that I hear a loud click. The patient will say, I hear a grating sound, or where they might say they hear a crackling sound. And that is the sound of crepitation. And that is primarily because of a permanent disc dislocation, or also probably because of disc perforation. So here is a diagram that we can definitely pause for a few seconds to show you what the normal relationship of the condyle and the disc is, as shown in figure A. Then we looked at the figure B, which was the disc displacement with reduction. The figure C shows us disc dislocation without reduction, where there is no clicking sound. Then you have the impingement of the retrodiscal tissue, followed with the condition called the retrodiscitis, where the patient reports to us with severe pain and probably a posterior open bite. And lastly, if the condition is not treated, the patient might lead himself or herself into the condition of osteoarthritis. In tomorrow's sessions, we will be reviewing some radiological evidence of these conditions, especially osteoarthritis, and that can be seen very clearly on a CBCT. Like I mentioned, some of the functional disorders of TMJ may also have some signs and symptoms along the dentition, and those are mainly the mobility, the pulpitis, the tooth wear. Oftentimes, these TMJ patients will have a collateral symptom of a headache or a migraine. And if we treat the TMJ symptoms, if the migraines are getting better, then those may be the secondary migraines associated with TMJ. But a lot of times we tell the patients that headaches and migraines are not our primary, not a primary marker of TMJ treatments, and we would like to take care of their pain in and around the TMJ. In tomorrow's session, we will relate all of this information as from an orthodontic perspective, and not only be able to diagnose if these conditions are presented by our orthodontic patients that are undergoing treatment, but also hopefully be able to diagnose these conditions in a TMJ patient and see if a splint therapy followed with orthodontic treatment might be a reasonable treatment option for some of these TMD patients. So to quickly go over the diagnosis of TMJ disorders, we know that the diagnosis is the key, and success does not depend on how well treatment is performed, but rather depends on the appropriate treatment that is delivered after the correct diagnosis is made. I'll pause now to see if there are any questions that we can answer, and then we can continue with the rest of the presentation for tomorrow. Dr. Manju, can you still hear me? Dr. Manju?
Yeah. Yes, Dr. Abijit.
There are some questions from the question bank.
There are some questions for today.
Okay.
I think not many, but I will just read out. The diagnostic aids and treatment of these disorders to be discussed tomorrow. Okay. So how do we treat a case if the patient has deep bite and need to want lowers in which we might give a bite block? Does it worsen the problem if the patient is already having it?
That's a great question. So usually with a class 2 deep bite, if the patient has an underlying TMJ condition and has reported of either clicking and popping and or pain, then what I normally now do is we treat the TMJ condition first. We treat the TMJ condition with a splint therapy, and we'll show that's the splint design tomorrow. And we will take care of the TMJ problem first, wait for about 4 to 6 months until the patient says that the TMJ condition has resolved, there is no more pain. If there is no more pain, then from that point onwards, I will proceed by treating the upper arch with braces, followed by lower arch with braces. So we'll go through those steps tomorrow. Step 1 is splint therapy. Step 2 is orthodontic treatment, starting with upper arch. And step 3 is rolling into the lower arch braces.
Okay. There's one more question, a very interesting thing for the recent times. Nowadays, people are shifting into clear aligners. So what is your take on this? Because they'll be wearing it 24 hours for at least a period of 1 year. So
yes, that is a very important topic for us as orthodontists, because there's a huge uptake of aligner treatment for adult patients. And unfortunately, a lot of times patients come in asking for a very aesthetic appliance. They don't want braces. They want to treat their malocclusions with aligners. If the patient has any underlying TMJ condition, we tell the patients throughout the aligner treatment is that the day they report of any pain during aligner treatment, that we will have to pause their treatment to make sure that we relieve the TMJ symptoms. And oftentimes, adult patients, they want to just correct their alignment of the teeth. They may or may not report to you that they had some existing TMJ conditions, because to them, they may not relate the alignment of the teeth to the importance of a healthy TM joint. So the history taking is very important during those treatment consultations. So we do a thorough TMJ examination. Usually in our practice, we'll do a CBCT. We'll review the TM joint and a CBCT exam as well with the patient. But in the lack of a CBCT, as we know very well, history taking is the most important part of diagnosis and treatment planning. And so if there is TMD symptoms mentioned, then that's when I interject the patient and I say, at any point during your course of aligner treatment, if there is TMJ issues, we may have to pause. Many of you might be practicing Invisalign and or other aligner systems that offer the use of virtual bite turbos. And so if the conditions of TMJ are not very severe, then I've incorporated the use of virtual bite turbos for those patients, so we don't load those joints by the constant clenching down on the back teeth.
And probably we should take care to take the consent form.
Absolutely, yeah. I'm sure your standard consent forms have that language, but
yes.
With our consent forms, there is always a mention of TMJ, and the patients usually don't read those consent forms. So one of our team members will usually read the consent form for them so that they understand what they're consenting to.
Okay. There's one more question. Are we as orthodontists creating an etiologic damage when we raise a bite or the bite turbo during the orthodontic treatment, or is it a temporary effect?
So I think that is a very debatable topic. And like I mentioned, I'm not in academics or full-time research, and we have a lot of stalwarts on this program right now, as well as others in the departments that can attest to that. But in my clinical experience, when we place biturbos, a lot of times the posterior biturbos may cause some transient pain or discomfort. If you are incorporating an anterior biturbo, I haven't faced too many times where the patient is reporting of jaw issues. But in my opinion, at least, these are transitional or transient problems that we are looking at. I don't think we are creating a permanent damage by allowing the biturbos where the placing the biturbos where we are allowing the lower teeth to kind of rest on them. Most of the deep bite cases, I will personally place anterior biturbos, but I know as orthodontists we have used biturbos on anteriors or posteriors throughout treatment as necessary.
Okay. I would ask Dr. President, sir, Dr. Silju, sir, do you have any questions, sir?
No questions. I must just congratulate Dr. Abijit Gune for a wonderful lecture. I think you have to put things in perspective, and there's a lot of clarity on the management of TMD. And I must say that it was a wonderful lecture. Really appreciate it. Thank you.
Thank you, Dr. Matthews. I hope to put this lecture, which is just the introduction of TMJ, the common conditions that we see in our clinical practices, and we can take these from today and then tie it into our clinical practice, where tomorrow, I can share with you the splint therapies we use for these patients, as well as the orthodontic perspective on how we treat these TMJ patients with splint therapy first, followed with orthodontic treatment to kind of hopefully treat these TMJ conditions.
Okay, thank you, sir, and thank you, Dr. Abijit. I think we will have more interesting sessions for tomorrow and more questions probably. Okay, so
Definitely.
we will, and I'll thank all the participants for taking part today. We will request all of you to assemble tomorrow. We will join in at 9 sharp at 9 o'clock. Very good morning to all the iOS office bearers, Jaydev sir, Dr. Abijit, and all the participants who are early today. So we didn't want you to miss the academic session and the learning session by Dr. Abijit. Probably he will take more time today. So we wanted to start a little early. And our iOS office bearers are also busy today after this session. So I would like to take this opportunity to thank President sir, Secretary ma'am, and the other iOS office bearers for providing us this iOS Zoom platform to conduct this program, and all the support and encouragement to conduct such an academic learning session. So we would be very grateful to you, and we would like to do further programs like this in before.
A very good morning to one and all, Madam Secretary, and all the EC members present here. Respects to Dr. Vijay Jaydev sir, speaker for the day, Dr. Abijit Gune, Principal Madam Dr. Vinay Pai Madam, and the dynamic moderator Dr. Manjunath Hegde, and all the faculty at the BIDS College and attendees. Really happy to be here today. The first webinar being hosted by BIDS in association with BOSG. And yesterday was the first day. Dr. Abijit had given us a clear insight on the management and various clinical aspects of TMD. And today is the second day. We look forward to an interesting day of knowledge enhancement and broadening our horizon on TMDs. So I wouldn't take much time. Everybody's here to listen to Dr. Abijit Gune. So with these few words, I'm wishing the session a great success. Thank you all and have a great day. So,
Secretary ma'am.
Yes. A very good morning to all. Good morning, Jaydev sir, President iOS, Dr. Vinaya, Dr. Manjunath, and of course the speaker for the day, Dr. Abijit. It's a pleasure to see you, if only virtually. I must confess that I was not there for the entire lecture yesterday, being a working day and being in college, but I heard very good things about it. And I understand that today is a continuation, and I can see that already so many people have joined in quite early in the morning. And best wishes to the organizing team and congratulations on a program very, very well conducted. Vinaya Madam and Dr. Manjunath and team. Thank you so much for inviting me. Best wishes.
Jaydev sir, would you like to speak to your student, Dr. Abijit?
Good seeing you, sir.
You have to unmute yourself.
Hello, Abijit. Good to see you.
Hello, sir.
Yeah.
Good.
Nice talking to you and eager to listen to you now.
Thank you, sir. Thank you very much for being here, and thank you for all your blessings over the years.
Yeah, sure. Yeah, please go ahead.
Thank you.
Okay. With that, thank you, Silju sir and Sridevi ma'am. So we will start with we'll hand over the stage to Dr. Abijit, and we will start off. Thank you, ma'am.
Thank you, everyone. Thank you for coming back for the second class. I hope I did not bore you yesterday with all the academics part of it. Today, I promise that it will be more clinical stuff. Hopefully, at some point, we could do a hands-on as well. I'm hoping that Dr. Manjunath will text me or WhatsApp me if there is any problem with the Wi-Fi connection. With that, I'll share my screen. And give me 1 second so I can move my menu bar here. Can you all see my screen okay?
Yes, Abijit.
Okay, thank you very much. So yesterday we spoke a little bit about the academics part, just to kind of get to know what the TMJ anatomy looks like and what are the possibilities of the TMD aspects that we are going to see in our clinical practices. Today, I'm going to time myself really well and not spend too much time with all the boring stuff. However, I like to go through these points that I have. One is about the imaging of the TM joint. And then secondly, we'll dive into treatments of TMDs, including the interdisciplinary approaches. And lastly, our favorite topic, which is the orthodontic management. My goal today is to make sure that all the attendees are aware of what our role as orthodontists can be in the management of TMD. And we already have a very strong basis in learning, growth, and development, and that carries forwards into management of TMD as well. So let's talk about imaging of TMJ. Technology has caught up with us now where we have access to a CBCT, a CT scan machine in our dental offices. And that has definitely enhanced our abilities to diagnose TMJ conditions in most of our patients. Back in the day, we would have the regular lateral view of our TM joints. We rarely do that anymore, so I wouldn't speak too much about that. The CT machines, of course, are available only to the medical professionals, but we do have to our disposal now the cone beam CT, which is where I'll share a few slides on what we routinely do and what slices we routinely see for our patients. Lastly, the MRI, which is the gold standard for diagnosing any conditions associated with the disc and not the hard bony structures of the TM joint. We do have access to a panoramic X-ray, but you will see soon why the panoramic X-rays by themselves may not be best or well suited to do our TMJ imaging if we are to dive deeper into treating TMD patients. So here's a typical view of a Panorex. Most of us have access to a Panorex. You will see that there is a lot of disturbance in the image. The image is not very clear along the jaw joints. And of course, as we all know, this is just a two-dimensional representation of a three-dimensional joint. So we, of course, in our practice, do not use the panoramic machines anymore. Luckily, we have the access to an iCat machine. and that's where all our imaging is done. But if you do have, an access to a panoramic machine and that's all you have, well, you can definitely study the jaw joints or try to study the jaw joints on panoramic X-rays, and I'm sure you will be able to enhance, some ability there, some skill there to diagnose some of the TM joint conditions also on a PanRX. But if you have access to a CBCT, that's definitely the way to go. So coming to the cone beam CT directly without wasting too much time, we have the full 3D view of our jaw joints. And so you can dive in deeper in all the 3 planes of space, and you are able to visualize the joint with no disturbances or, a very clear view of the jaw joint itself. So this is a coronal TMJ view that is shown on the screen, and that identifies the probability, of an early degenerative joint changes along the left jaw joint that you see on the right-hand side of your screen. These are showing the various sections that we will slice and dice the panoramic, the CBCT view for our patients. We will go through all of these slices looking for what we otherwise would refer to as beaking of the condyle, which again is not very clearly visualized on a panoramic X-ray. But I have a few slides later on as we come to the case reports, and you will see anytime a patient has a history of clenching and grinding, you will see these early signs of flattening of the condylar head, as well as the typical description of beaking of the condyle. I'm going to pause for a second here. I'm going to minimize my screen on the view if I can. I cannot. I don't know how to do that part. Pardon me, this is my first ever Zoom presentation, so I'm still technically challenged on certain aspects of presentation. So this is our sagittal view, and this is the view where you can clearly start seeing on the right-hand side the different slices of the jaw joint, and an early diagnosis of the TM joint disorders can be made by visualizing this sagittal cross-sectional views. The beaking of the condyle usually starts showing early on with a history of a clenching or a grinding of teeth at nighttime. The cone beam CT, as many of you would know, also gives you this particular volume rendering images of the entire patient skeleton, and you can rotate these volume rendered images in all planes of space, and really have a good view of what the patient is presenting to you, not just from a TMJ perspective, but also from a skeletal discrepancy for a regular management of an orthodontic patient. Needless to say, its advantages for impacted canines and things of that nature. So here is diving a little bit deeper into that view of the TM joint, where you can clearly see without any shadowing of other structures, the superior border of the condyle. And as you can see, the 3 different images represent 3 different stages of the early degenerative changes. The image on your bottom left-hand side, where you see a gross destruction of the articular surfaces, is clearly a sign of major pathology, usually associated with severe pain for these patients. As I mentioned, MRI is the gold standard for imaging the soft tissue disc. The one disadvantage of a CBCT is, although it talks about in volumes about the hard tissue structures of the joint, we really cannot diagnose what is going on with the disc itself, since the disc is a soft tissue. So in our offices, usually the cost of an MRI is fairly high to the patients. So we rely on a majority of the time with the clinical history and management. And at the end of our 4 to 6 month period with the TMJ management for these patients, if the patient is not having any resolution in terms of pain, then we would refer the patient to a neighboring radiology clinic for an MRI to diagnose deeper into that, to see if we need to refer the patient to the oral surgeon. We don't need to waste too much time on MRIs, so we can move on to the other aspects of TMD management. But the one thing I would like to mention is that this, of course, it's a non-invasive technique using a magnetic field. So patients who are concerned about radiation, then those would be the patients we would refer them to for an MRI, letting them know that this is an expensive investigation. This is I personally myself do not read any of the MRI images. We use a radiology service available to us. So if a patient is sent to the radiology clinic, then the radiologist on site would send me a report back about the condition of the disc. But this is just an example for all of us to look at, is that you can see here very clearly that the bone actually appears to be darker on these images than the disc itself. The disc is the whiter part, over the condylar head that is shown there. So it's a little bit of a different interpretation for MRI, and we clearly as orthodontists have not been exposed too much to reading of the MRI images, so we rely on our radiologic colleagues. So jumping into the treatments of TMD, that is where all of us are interested in. And like I said, one of my goals for the talk is that we all become familiar in our practices to diagnose TMD in our existing orthodontic patients and not be fearful of those conditions, but going one step beyond that to reach out to your community and say, well, I have a special interest in treating TMJ patients, and reaching out to those patients who otherwise have not had any help over the years. And some of the case reports that I've included, you will see that patients have gone as long as 30 years without seeking any beneficial treatments. So I will talk about general considerations. We'll talk about interdisciplinary referrals. Our main objective here is to look at the orthodontic perspective. And that's where I would like to talk a little bit about the phase 1 and the phase 2 treatments we do in our office. We spoke a little bit about this yesterday. Diagnosis is the key. Sometimes the diagnosis for a TMJ conditions is a single cause. It could be a trauma that the patient relates to from a few weeks ago to as long as a few months or years ago. Sometimes the trauma is unknown and it is ongoing. For example, parafunction that happens very likely in a sleep apnea patient. And often as clinicians, if we just try to treat the effect, then the cause is going to remain and we would never succeed in relieving these patients of the painful conditions that they have been living with. The treatment, from what I learned, is always or should always be conservative, reversible, and non-invasive. And this is the initial treatment. By initial treatment, I mean when we start diagnosing TMJ conditions as a new patient, we never wanted to offer a treatment to this patient which is irreversible, which cannot be changed. And the classic example that we see is a lot of patients will report of TMJ pain to their general dentists. And after doing a good clinical exam, the dentist may find that he or she needs to adjust the cusps of certain teeth, and they may pick up their hand pieces and start drilling on the teeth in order to save this patient from the painful trauma. That, in our opinion, of course, becomes an irreversible treatment. So my initial treatment is always going to be conservative. It's going to be reversible and hopefully non-invasive. Once I figure out that the cause is being altered and I'm helping the patient, then I start talking about the phase 2, which is the irreversible form of treatment that the patient has agreed to because he or she has realized that they are feeling better and the symptoms are going down. In our offices as orthodontists, occlusion could be a major cause for these cases that we see complaining about TMJ pain. And there what we are looking for is not just the dental occlusion, but more of an orthopedic instability. We spoke a little bit yesterday about the musculoskeletally stable position. And that's what we're looking for when we're diagnosing TMJ conditions in these patients. So needless to say, history taking is very important. A long ways beneficial to us as clinicians is to patiently listen to what the patient is actually telling us. If we listen to the patient really well, then we really do not need any of these modern diagnostic techniques, including the CBCT. A lot of times we'll spend about 5 or 10 minutes purely listening to the patient, trying to get as much history as we can. A very typical way, complaint would be, my jaw is very painful when I wake up in the morning. And, as orthodontists, if we are focused on their malocclusions and trying to see if every malocclusion has to be corrected in order to fix the problem, then we may have missed the boat, because the condition the TMJ condition may have started because of some other reasons. Now, the other thing we look at in the clinical exams is the mandibular restriction or the range of motion. And we've all seen and we've all done this in our clinical exams, but I will point to one particular condition that all of us, hopefully, when you get to your offices and clinics, you will start noticing is the mandibular deviation versus the mandibular deflection. And the typical concerns there are, the patient will say, well, it hurts to open in a certain direction. So we listen to all of these conditions. And here is an example. By what I mean is look, as an orthodontist, we look at this picture and we say, oh, that's a posterior open bite. This may be because of some reason, or a case was not treated well. And we can come to a conclusion by just looking at one picture. But knowing what you know from TMJ conditions, my immediate thought would be, well, could this be a TMJ condition that we spoke yesterday about, retrodiscitis? So if I see my treatment coordinator has taken the pictures, I'm visualizing the pictures before I get to the consult room. And if I see a posterior open bite, my immediate question to the TC is, has the patient spoken about TMJ history? And she is now good. She would have already asked that questions, and we would start, coming to our differential diagnosis based on that history, and not just looking at the clinical picture. This is a picture of what I mean by deviation versus deflection. In deviation, if you see a patient opening his mouth, his or her mouth, and the mandible now deviates to one side, but as they fully open, the midlines are more or less matching, then I'm immediately thinking of disc displacement with reduction. And it happens a lot when our patients are in braces and we give them heavy elastics. The patient may start complaining about TMJ clicking. Well, if it's just a clicking, then when they come back to the office and I'm checking their mouth opening, I'm looking for this deviation. And if there is a deviation and the midline comes back to normal, then my immediate next step is to palpate the jaw joints to see which joint I can feel the clicking. But the other condition is, and this, by the way, the deviation, like I said, is disc displacement with reduction. And we spoke a little bit about that yesterday. The other condition is, which is a little bit more severe or serious, is if the mandible is deflecting to one side. If the mandible deflects to one side, then my immediate thought is, okay, this is clearly a condition called the disc displacement without reduction. Now, typically, and I think I have a slide coming up next in the next few slides, where it shows you which side is going to be affected. And if the mandible is deflecting in this picture to the left side, I know that the left jaw joint has the condition, which is the disc displacement without reduction. And the right side could be a normal joint, or it could also be a clicking jaw joint, telling us that this could be a disc displacement with reduction. So sometimes the patients may have more than one condition. So you want to listen to them carefully as they're giving you the history. And yesterday somebody asked about aligners. That was a great question. A lot of times our aligner patients, if we have not checked the history of TMJ and they are in treatment and they are complaining about an inability to open, or it hurts when I open a certain way, then that's my immediate reaction, is that maybe I missed taking the TMJ history. Maybe I should have listened to the patient prior to starting my aligner treatment. I do have a case to show you later on where what we do with patients who have a known history of TMJ. And I also have included a slide of a emergency splint to be used in these aligner patients. So here is a good slide for us to look at, because this could happen in everybody's practice, a patient complaining in aligner treatment, complaining of TMJ pain. I use a tongue depressor stick, very readily available to all of us as clinicians. and I have it chair side by all the chairs. The minute a patient complains about TMJ pain, the first thing I do is get, obviously do our clinical exam, but to start differentiating of what could be going on. If the patient complains of pain on my right TMJ, I'll have the patient bite on a tongue depressor stick, and the patient is scared to bite down on the stick, but I'll let them know, don't worry, we're going to control this. Slowly start biting and slowly bite harder and harder. And if the patient is biting on the right side and there is no pain, then I immediately know that the patient has intracapsular pain on the right side. But if the patient is biting on the right side and the pain doesn't go away, then I know that this is not intracapsular, but this is probably local muscle soreness. So that's how we start to differentiate between a true TMJ pain versus the muscle pain. And it's important because our patients trust us. They are in aligner treatment, getting their teeth aligned, and they don't want to have the issue of a TMJ. So if I know that this is local muscle soreness, I can assure the patient, don't worry, this is not a TMJ condition to be concerned about. This could be from your clenching habit. So I'll discuss more about that with them. And here's that bite stick that I was talking about. It's just a tongue depressor, looks like a popsicle stick, just a little bit harder, that we carry in our offices. So have them slowly bite on that right side. If the pain reduces, we know it's intracapsular. I will pause the aligner treatment, give them a temporary splint, see them in a week or 2 weeks. If the pain is disappearing, then I know that I missed the TMJ condition in my history taking, and I will go back and I let the patient know, well, we don't want to continue with the aligner for a few weeks until we get the TMJ under control. What is that reversible therapy I was talking about? So this, of course, now goes back. This particular patient has not started aligner treatment or is not an orthodontic patient, but is a new patient to me who has come seeking help for TMJ pain relief. So the first thing I would do is I would take my history, and if I feel that the patient would probably benefit, this is something intracapsular and would benefit from a splint therapy, then I will design this splint for these patients, and I'll say, wear this for about 3 weeks and let's see if there's any change in the symptoms. If there isn't any change in the symptoms, then I may have to dive a little bit deeper in the diagnosis of the TMJ condition. But this is a reversible therapy. I'm not changing the patient's bite. I'm not adjusting the enamel. I'm not doing any odontoplasties. This is a purely reversible therapy. What I don't want to do on that day is pick up my handpiece and start grinding the teeth, trying to get their teeth to fit each other, because that is an irreversible therapy. So this is not something that I do for as a first resort to any of our patients. This does happen in a lot of general dental offices where the dentist feels compelled to help the patient and picks up the handpiece and starts adjusting the teeth. So coming to the interdisciplinary referrals, we talk often about working with our colleagues, but in the field of TMJ, we have to remember that dentists are not our only colleagues. We have other colleagues in the non-dental fields as well. And at least here, we do have the ability to team up with a physical therapist, a psychologist, even an acupuncturist or a massage therapist. And I'm sure within your own regional areas within India, you can start forming little teams and start to educate, colleagues in this non-dental professions about TMJ and see if they can, if you can team up with them. So we use our physical therapist a lot. We often find not referring our patients a lot to a psychologist, but we do have an acupuncturist in our neighborhood where we refer patients to. And although we don't refer our patients to a massage therapist, we do talk to the patients about massage therapy, themselves, that they can do themselves. Physical therapy is great. They do a lot of different, they help the patients in a different ways. But again, this has got mostly to do with muscle discomforts, muscle stretching, jaw stretching exercises, ultrasound treatments, iontophoresis, and things like that. We will not spend too much time on that. I just wanted to introduce to you that we do want to work with physical therapists as we are dealing with TMJ patients. Moist heat, ice packs, these are all normal things we can do for our patients, and they can do these at their own home. They don't even have to visit a physical therapist for that. But something like a coolant therapy and muscle stretching, the physical therapists are more geared and more trained to do something like that. Or iontophoresis. This is something, of course, that the physical therapy offices have, and something that the patients cannot do that. Although you can buy these units called the TENS units, and the people, patients who have chronic TMJ pain have actually ended up buying these units for themselves to constantly relieve the muscle discomfort. Psychologists, like I said, I have personally referred maybe 1 or 2 patients in the last few years, but we are not trained to be able to diagnose the emotional stress and the trauma that these TMD patients have. So just remember, I will not spend any more time. Just remember that sometimes you have to rely on medical personnel, a psychologist, not a psychiatrist, to help these patients as well. They may give the patients as simple as exercise as relaxation, and that also sometimes these patients enjoy. Acupuncturist is, of course, it is a well-known Chinese medicine, not very popular in the United States. However, providers treating TMJ patients have found huge benefits in the technique called dry needling. These, I have a picture for us to see, but these are done. There are multiple sessions that the patient has to go to. And here is what that looks like. So although patients do find benefit with these, some patients find benefits with these techniques, it is a cumbersome approach because the patient has to visit the acupuncturist for X number of visits throughout the 2 or 3 week period. So we refer some of our patients. We don't insist that all patients see an acupuncturist. And massage therapy, as simple as just massaging your masseter muscle. There are some exercises for the lateral pterygoid muscle, which is a little harder to reach, but with your small pinky finger, patients can also massage the lateral pterygoid muscles to provide themselves some relief. Now, talking about the dental referrals, we do rely heavily on radiologists, like I mentioned, for MRI interpretations. We also refer our patients to our local oral and maxillofacial surgeon. There are definitely times where we need their help. But I think, at least in the United States, a lot of the patients are stepping away from the surgical management of TMJ for cost reasons, and just they're scared of having any surgeries. But there are certain patients that will definitely require that. We do work with our local prosthodontist, and I'll talk a little bit about that in our phase 1, phase 2 treatment plans. And then, of course, our general dentist, because we want to keep them updated about the conditions of the patients and what to do and what not to do for these TMJ patients. And what not to do is a very simple statement to the patient and a request to the dentist that when these patients visit them every 6 months for their routine checkups, that the dentist always offers a bite block and not have the patient keep their mouth open for too long, for too wide. That's going to affect the jaw joint. So we inform the patient and we request the dentist, and we hope that they follow that all the time. So here's the main slides for today. Role of orthodontists. What do we do and when do we do? So phase 1, we talk about TMJ disc displacements, which are the primary referrals that we get in our offices, and what do we do for them. And then phase 2, whether the patient wants to do just a phase 1 treatment, manage their pain, or if they want to really treat the cause, and that's where phase 2 would come into effect, which is orthodontics alone or in collaboration with their prosthodontist or a general dentist to restore the vertical dimension of occlusion. So in phase 1, we talk, like we spoke about yesterday, we talk about disc displacement with reduction. What do we do as a phase 1 and a phase 2 for those conditions? And then what would we do for a patient who has disc dislocation without reduction? And so we'll talk to the patients about their treatment approaches. Most times, if the patient has a disc dislocation without reduction, then most times I would stay only with phase 1 treatment approach and not necessarily talk to them about a phase 2, because as we learned, once the disc is once the disc is dislocated, sometimes it becomes very difficult to recapture those discs. So here's just a slide from yesterday that shows you the disc in the right direction, which is slide A, and then this that is dislocated forwards, which is slide B. That's this displacement in slide A. That's this dislocation in slide B. So this is just a review from yesterday. So here is one of the classic examples that we'll see in our offices, a class 2 div 2 malocclusion with a deep bite. And yesterday somebody asked a question about what do we do in these conditions? Should we place a bite turbo, and will the bite turbo negatively affect the condition for the patient? So as we know very well, a class 2 div 2 malocclusion can definitely be a risk factor in the long run for a disc displacement with reduction. Sometimes these patients come to us and they already have joint sounds that we can, they have identified, and we are able to feel those or hear those joint sounds. And sometimes we see that mandibular deviation, not a deflection, but the deviation during their opening. So we, in a lot of times we'll see patients in the age group of 13 or 14 with these clinical findings, with a deep bite and a class 2 div 2 malocclusion. And then it's our job to inform the parent is one of the risks of not treating this condition is your child could then develop TMJ conditions down the road. This is the deviation I was talking about, very typically seen in a class 2 div 2 malocclusion. Always think disc displacement. So do not think just on how I'm going to correct the malocclusion, but is there an underlying TMJ condition that I have to address? Now here we have done the initial treatment. Now we are talking about definitive treatment. How can I reestablish the proper condyle and the disc relationship? How can I relieve the loading of the retrodiscal tissue, which is the primary reason for pain in these patients? So what we do is we find an anterior position of the jaw, which is the centric relation, to where we want to have the patient be able to position the jaw in a most comfortable manner. And for lack of time, I did not include all the slides in that, but we'll do the phonetic evaluation as well. Once we find out the correct position of the jaw joint, we will find out, or we will try to find if that particular position of the jaw, will eliminate the joint sounds. Now, in this case, we have found out, this goes to the technique first introduced by Farrar in 1970, which talks about an anterior repositioning splint. So if I can find out a position of the patient's jaw where I'm getting rid of the joint sounds, then that's where I want to try and position my patient's mandible. If I can position that mandible and capture that mandible with an anterior repositioning splint, then I want these patients in those splints for the first about 3 or 6 months. And that's going to hold their jaw more forwards. And now I'm going to reestablish the vertical dimension of occlusion by means of orthodontics or orthodontics and prosthodontics combined. So here is an example, and we'll go in detail about how to fabricate these appliances. I want to make sure that I watch my time here, but we'll go in detail about fabrication. But this is a classic anterior repositioning splint that we do in our office. You can see that there is a little ramp that is created on the upper splint. The upper splints typically I have the patients use at nighttime. For the first 3 weeks, I have them use it full time, day and night. As you can imagine, a lot of the patients, they find it very difficult to use this design during the daytime. So I let them know ahead of time that this is a very tough decision they have to make. Do they want to control the pain on a temporary basis, or do they actually want to treat the cause? And if they want to treat the cause, then they will have to bear with this particular design for the first 3 weeks. I have them wear the appliance for 3 weeks full time, and then I'll give them a lower splint for daytime use, and then this upper splint, they will use it for nighttime. So this has a guiding ramp, and this is the typical design for an anterior repositioning splint. Now, what happens if there is a disc displacement without reduction? I cannot bring the jaw forwards, and I cannot recapture that disc. Remember that the patients have first told you that there is severe pain, and if you listen carefully, they might say that they used to have clicking and popping a few months or a few years ago, and now they are not able to hear it at all. The other classic condition when they come to our sign that you will see when they come to the office is that they are not able to open their mouth wide enough because there's only mostly a rotational movement of the condyles and not a translation. So that's your cue. If they are not able to open wide, you know that there is a disc displacement without reduction. Then immediately fall back and start asking questions about when did they first notice this? Because if this is an acute condition, then we can do what we call the mandibular distraction and actually force the condyle downwards and forwards and try to relieve that the inability to open. But if it is a chronic condition and the patient reports that this has been like that for months, let alone years, then of course there is not much I can do about a phase 2. I will purely talk to them about a phase 1, which is splint therapy. In these patients in chronic conditions, the anterior repositioning splints are completely contraindicated. And we'll talk about a stabilization splint for those patients. So classic condition, like I said, range of motion is affected for disc dislocation. There is no clicking, there is no popping, and the deflection is to the ipsilateral side. So if the patient opens and the jaw deflects to the left side, you are very sure that it is the left disc that is out of alignment, and that is the disc cannot be reduced. That is called the ipsilateral deflection. And that's the picture I showed you earlier. And that's the graphic representation again, just to show you what happens with the disc displacement. And that's an MRI on the bottom right-hand side, showing you that the disc is kind of folded and is more anteriorly displaced ahead of the condyle. You never want to fabricate a anterior repositioning splint, because with that position of the mandible, the disc is only going to collapse even more. So those are highly contraindicated for these conditions. But what if the case is acute? The patient says, well, I used to have clicking and popping, and just about a week or 2 weeks ago, the clicking has gone away, but I noticed that I cannot open wide. Well, that's a good sign, because we know that the joints used to click. This is when we will employ the technique of manual manipulation or distraction of the joint. And the distraction of the joint is very similar. We've all done that in dental schools when the patient have had an open lock. We've put our thumbs down on the second molars, and we have pulled down on the lower jaw, slid the jaw forwards, and try to relieve that. So in this case, we're not going to relieve that by just sliding the jaw forwards, but we want to actually push down on the mandible and pull up on the chin. And then you keep manipulating the jaw at least 30 or 40 times to see if by doing that, if the patient is now slowly able to open wider. If they're able to open wider, and now I can pull the jaw forwards, then although you will not hear the clicking joint sound, I know that I'm able to distract the jaw forwards, and I'm going to fabricate an anterior repositioning splint in that position. So again, remember that this is a condition where there is disc cannot be recaptured otherwise, because it's a chronic condition. But if it's an acute condition, we can manually distract the joint and then fabricate a repositioning splint. So this is a picture to show you how to push down on the mandible and pull up on the chin, and then constantly open and close the jaw for several repetitions to see if we can open the patient's range of mouth opening. So again, anterior repositioning splints can be fabricated. We have the patients use it for 7 days full time. See if the patients come back to us in a week and say, well, doctor, now my jaw is clicking. And to them, it doesn't seem like it's a good thing, but internally I'm smiling because now I know that we have gotten the patient back into the disc displacement with reduction situation, which we know we can treat with a phase 2 orthodontics or orthodontics and prosthodontics combined. But what if the patient has a chronic condition? Well, this is the description of a stabilization splint. A stabilization appliance is bilaterally, equilibrated, but it is not putting the jaw in a forward position. Again, I want to find out what is the most musculoskeletally stable position, and I want to fabricate the splint to hold the condyles away from the retrodiscal tissue, which is where the pain is coming from. So in these patients, I tell them that there's not much I can do other than fabricate a splint for them to be used mainly at night time. But if the pain is severe during the day, then we'll also recommend that they use this during the daytime. And this is the disc displacement, the chronic condition. Supportive therapy, if these patients, they are chronic situations, they cannot open too wide, we let them know, just remember that this is your limitation for your jaw joint. Had you come to us few years ago, we may have been able to help you, but in this situation, wear the splint at night time, and during the daytime, make sure that you avoid opening too wide, avoid opening too quickly, avoid biting on hard foods or repetitive motions, and that's most typically like chewing gum and things like that. Sometimes the moist heat will help with the muscle soreness as well, and of course the NSAIDs. There is a condition we sometimes will see, and I showed you a video about subluxation. This particular pictures is showing you essentially what can happen in an adult patient who otherwise is not interested in orthodontic treatment, but is concerned about the subluxation. Well, as orthodontists, we have all of this armamentarium in our offices, and we can place a few buttons. We can, the elastic chain that is shown on the bottom is purely to show the patient when you open the mouth, the elastic chain should not be stretching beyond this limit. And they have to constantly monitor that. We have these patients be in that in this particular appliance like that for about 3 months. And what we are trying to gain there is just muscle memory, letting the patients know that there is a limit on how much they can open, and that subluxation is not necessarily a pathology, but it could be a normal variation or within the range of normal variation for these particular patients. Last but not the least, osteoarthritis. As you start treating TMJ patients, the worst condition that we know for TMD is osteoarthritis, also known as degenerative joint disease. This history is very, very specific. Years and years of clicking and popping. Suddenly the clicking and popping has gone away. The patient has still not sought any help from a professional. And now they are coming to you because of intense pain to where they simply do not want to keep their teeth together, which of course, as we know, has to be done every day when you're chewing, your regular meals. That's when the patients try to come to us to seek help on what can be done. The big difference in these conditions, although the jaw joint is not clicking and popping, as you hear the range, as you hear the movement of the jaw, you will start noticing the crepitations. And that is a very classic sign. We looked at the imaging on a CBCT. You will see a lot of destruction of the superior surface of the articular surfaces of the condyle. And these are the conditions where we'll definitely refer the patients for an MRI to confirm the position of the disc. This is the same picture again. On the bottom left-hand side, you will see this severe destruction. That's a condition definitely called the degenerative joint disease. What happens in these conditions? The other, sometimes, and I've only had one patient report to me with the change in the bite. They suddenly had developed an anterior open bite. She knew that she had pain in the jaw joint, but she had never sought help for years. And now she was back in our office to find out if I can help her with the malocclusion. When we did her jaw x-rays, we were amazed at the loss of articular tissue. And I told the patient, there's not much I can do to correct the malocclusion because of the nature of the destruction of the condyles. So we kept her in a stabilization splint. And I told her that's her best bet unless she wants to go in for a distraction osteogenesis and things of that nature. And in which case, of course, in our offices here, we would not do something like that. We would refer them to a university setting. And unfortunately, the patient disagreed with that, and she just decided to stay with a phase 1 treatment plan for a stabilization splint. So this is what I was talking about, fabricate a stabilization splint and then refer to the oral surgeon. And of course, in this particular condition, a oral surgeon tied with a university setting. Okay, let's get back into, we have about 20 more minutes. So I'm going to talk about fabrication of the splints, stabilization splint, and an anterior repositioning splint. Both splints are highly useful in our practices. And here is the first one, which is a stabilization splint. This splint I'll use mainly for patients with disc displacement without reduction. They have painful joints. They are coming to us mainly for TMJ help. They do not necessarily have any orthodontic conditions or malocclusions that they want to treat. So this is a classic stabilization splint, mostly done on the upper arch for nighttime, but you can also fabricate this on the lower arch. Here is my setup. A typical setup will include the liquid monomer and the polymer. And here is what we buy it from Great Lakes Orthodontics. And you can buy it from any of your supplier. This is the Combiplast base splint material we'll use. It's a 3 millimeter thickness, and it's got a hard and a soft. It's a bilaminar design. So the soft portion, of course, conforms to the teeth, and the hard portion is what we use to adhere the dental acrylic to that when we are fabricating the splint. We have a Drew format in our office. Some of us are exposed to a BioStar. If you don't have any of these in your offices or in the universities, I'm sure the university has it, but maybe your local dental lab can make you a base splint, and then you can use that base splint to then work in your office and make these stabilization splints. So you mix up the liquid monomer and the polymer, form a little resin block for about 3 millimeters. You apply that right behind the upper incisors. And now you take this particular splint in the patient's mouth, you put it in the upper arch, and then you're manipulating the jaw to find that musculoskeletally stable position. And then you have the patient gently bite down, not force their teeth together, but gently guide them into the correct position where you want them, where you can feel the jaw joints in the most relaxed position. Once you find the position, I hand the patient a mirror and I tell them to continuously watch themselves in the mirror to make sure that their jaw does not shift at all. And the acrylic takes about roughly 3 to 4 minutes to achieve its initial set. Once it's set, you can see that in this top picture, the acrylic is set. I have a positive stop where I want the patient to bite down on. When they bite down on that particular position, I do not have the posteriors contacting the base splint. But remember, I mentioned that we don't want to do anything that is irreversible in some of these patients. So I don't want to leave them in this splint design where the bottom posterior teeth are not touching the upper surfaces to allow them to supra-erupt. So I add acrylic to the back of that splint. I put the splint back in the patient's mouth, and now the patient bites down again, and the acrylic flows into that space. So the mandibular posterior teeth have a positive contact with the acrylic at all the times. Here's when the material sets. You have a little excess material. You take it back in your lab and you start polishing up the acrylic. You polish it up to where you now have a proper, well-designed splint where you have a uniform contact on both the sides. And that's showing that I just have every mandibular tooth touching the upper splint. So I'm not fearing that a tooth might start supra-erupting during this process. And here's the final splint. It looks like, the splint is well equilibrated. The drawings or the markings are there just to exaggerate for the presentation purposes. But you can find that, obviously the splint is well balanced. The second is the repositioning splint. These splints are designed primarily for patients who have disc displacement with reduction. So we know that we can treat these patients with a phase 1 and a phase 2 orthodontic treatment plan. Very similar in the look, except for the guiding ramp, and the way we fabricate them is a little bit different. So the first step is very similar to the repositioning, similar to the stabilization splint. I found myself a musculoskeletally stable position. I've guided the lower jaw into that position. The acrylic is set. Now I'm going to add a little bit more acrylic to that splint and form this particular guiding ramp. Once the guiding ramp is formed, I let that guiding ramp set for about 3 to 4 minutes. And then when the patient bites down on this guiding ramp, again, the mandibular posterior teeth are not touching, However, in these situations, the lower jaw is more forwards displaced because remember in our earlier discussion, we want that lower jaw to be anteriorly displaced where the joint sounds are eliminated. So this almost, for all of us, we are very familiar with a twin block appliance in kids where we are advancing the lower jaw forwards. And this is, done in teenagers and adults where, of course, we don't have the benefit of a functional appliance. But the lower jaw is advanced forwards. And now I'm going to fill up the posterior of the acrylic just so that the lower teeth have a positive stop. These appliances are worn by the patients for about 3 to 6 months if they want to, if they want to go to a phase 2 treatment with orthodontics. And I'll show you some cases on where we have done that on several of these patients. The next slide is one of the favorite slides, favorite appliances that I carry in my office. There's two things that I have for emergency use. One, on the left-hand side of the screen, you see a temporary splint, a company here that sells them. It's called Aqualizer, and it's nothing but a plastic tube filled with water and has foldable tabs on the back so that the patient, when they close their jaw, the back teeth, the bottom back teeth rest on these water pillows. And then the two pillows are connected with this water tube. So if a patient bites down heavily on the left side, the water kind of equilibrates in that tube and finds the right balance. So immediately as the patient starts wearing this, their muscles feel a lot more relaxed, the masseter muscle. And I say this is an emergency use because I mentioned, you may have an aligner patient, an Invisalign patient that's, is going well for a few months and suddenly they start complaining about TMJ pain. What do we do at that point? We've already started treating them with aligners. We are not going to throw everything away and fabricate a repositioning splint or a stabilization splint. So I carry these aqualizers in my practice and I let the patient know, well, let's find out whether it's truly intracapsular or whether this could be just a muscle discomfort. I also carry a small laser unit. They are not very expensive compared to the big laser units. And the BioLaser makes this particular unit that we have that is specifically targeting for the laser pain therapy for the muscles. So these two things we use for an emergency purposes. If the patients need it, we'll offer it to them, but they are not our primary usage. Well, we also are moving along now. I have some experience, not a whole lot of experience in fabricating 3D printed digital splints, but we did buy during this COVID pandemic, we ended up buying a 3D printer finally that we wanted. And now we are experimenting on printing 3D splints. Some of you may already know of Dr. Owen. He is a famous orthodontist who has designed this tripod splint. It's a upper and a lower splint, and the lower splint is built up to where we are able to, once we are able to find that musculoskeletally stable position, then the software will design the lower splint where it can articulate with the upper splint to achieve that stable position. So we just started using this for about a year or so. They work great in some patients, and some patients, I think that they should and they don't. So I'm not very, very well versed with this. The only challenge with these tripod splints, because they are digitally printed, is once we print them, we cannot go back and change or adjust them too much. We almost have to rescan, get a different bite, and then refabricate the appliances. So if I mess up, then it starts to add to the cost. But this is going to be the future. And so I definitely want to learn on how to fabricate these splints. And hopefully in the next 2 or 3 years, I would have mastered these splints similar to what I think we have mastered with the repositioning splints and stabilization splints. But I just wanted to show this to you because some of you may be exposed to 3D printing, and that's a whole new topic that you should look into as we move along in the future. So coming to the last segment, I know a lot of the audience members must be waiting to see, as an orthodontist, how am I managing my patients? So I have a few cases. I don't have much time but I have few cases that I'm going to review with you. And I chose, or I tried to choose, few cases in braces, one cases with Invisalign, one case with lingual appliance, and also just what we do for teenager patients who complain of clicking and popping. So here's the first case. You will notice that I think all of these cases, they're all female patients. At least in the United States, the prevalence of TMJ is much higher in females compared to males. There are some male patients we do treat in our offices. Somehow, it could be just the nature of being a man. They always don't want to reveal that they're in too much pain, and they certainly do not want to commit to an expensive treatment for a phase 1 and phase 2. So most of my male patients have limited themselves to a phase 1, a stabilization splint kind of a treatment. But here's some cases that I have, which are phase 1 followed with a phase 2 orthodontics. So this first case, 43-year-old female, she actually is a dental assistant in one of our local dentists. She has always been concerned about TMJ clicking and pain, but really did not know what to do. Her regular general dentist made her what they typically describe here as a night guard. And, a night guard looks very similar to a stabilization splint, but it differs from the fact that the dentist who sends the impressions to a lab to make a night guard has no clue where the patient's condyles need to be. So oftentimes patients in night guards complain of more pain when they actually wear it. So I'm always a little bit leery about the designs of the night guards. Upon examination, what we found out was, luckily, she had a disc displacement with reduction on the left side, but she did not have a disc displacement with reduction. She in fact had a disc displacement without reduction on the right side. So here's the dilemma that I had: is one side is with reduction and one side is not. And I told the patient, because she was from the dental field, I said the chances of success are a lot higher if these were disc displacement with reduction on both the sides. And she said, "Doctor, I trust you. Hopefully we'll get some benefit, if not the full benefit." So having that consent from the patient is very important. So we started treating the patient first with a anterior repositioning splint. And this is our initial pictures. And you can see that the right side, of course, is a class 2 malocclusion. The left side is a class 1 malocclusion. The midlines are deviated. Clearly, the left side was the jaw joint with a clicking sound that we could reduce. The right side was no clicking, and we could not reduce the jaw joint. Here is a panoramic X-ray. You can notice now this is a panoramic X-ray reconstructed from our CBCT machine. So you will see the clarity around the jaw joints, and we can reconstruct these panoramic X-rays from ICATs in whatever focal lengths we want, focal troughs we want, so we can get the proper landmarks identified. But here you can see that the right condyle is further posteriorly displaced, and the left one is not as posteriorly displaced. So clearly she was likely to develop the disc displacement without reduction on the right side. And these are the other slices like I said, we slice and dice the CBCTs. But here is at the end of 6 months. Here is her bite by doing a anterior repositioning splint. You will notice that as I advance the mandible forwards, I have not corrected her midline. The midline is still deviated to the right side because I know that the right side was a disc displacement without reduction. So I did not want to change that, but the left side now is a super class 1 molar and canine relationship. But there is definitely a posterior open bite, and here is where our phase 2 comes into effect. We tell the patients, most times we can do your phase 2 with orthodontics alone, but sometimes I will need the help of our local prosthodontist to restore your vertical dimension of occlusion on the posteriors. So she went into phase 2 with braces. As an adult, she chose clear brackets on the top. We do metal brackets on the bottom. These are the Damon Q brackets. Class 2 elastics. We know this particular routine. All of you guys know this routine day in, day out in the back of your hands. Nothing special there. The one thing I may not have included on these pictures is that post post repositioning splint, I'll always have a anterior bite turbo on the lingual surfaces of upper ones. And then we start with the treatments and employ class 2 elastics. And that is the end result. Again, the bites improved, the midline still deviated to the right side, yet we have a better molar relationship on the right side. Of course, at the end of the 6 months with phase 1, the patient still had no painful joint symptoms. There was no clicking and popping. And throughout the orthodontic treatment, she never reported back. If some of you are practicing the Damon philosophy, you may notice that we start early elastics and we try to stay in early and light elastics. So during the course of treatment, we are never giving the patients any heavy forces. At the end of the treatment, the patient would probably have if they have opted for a fixed retainer, I would give them a lower fixed lingual retainer on the bottom anteriors. And then I would give them a nighttime splint with an anterior ramp. But in this case, we are not displacing the jaw forwards. We are building an anterior ramp merely to help their jaw remain in that position at nighttime only. And during the daytime, of course, the solid occlusion is going to keep that jaw joint in the right position. This is the second patient, Donna, 58-year-old female. Again, looking for relief from headaches and jaw pain. And yesterday we spoke a little bit about headaches. I never promised any of our patients that doing these treatments is going to relieve their headache. We just simply don't know that. She was 58 when she saw us, and she reported that she's been having these symptoms since she was 30. So it's a long time to wait to be able to get treatment resolved. Again, same thing. I will go through these slides a little bit quickly because I know we'll have some questions at the end. Class 1 molar occlusion on both the sides. Oh, let me back up for a second. She had disc displacement with reduction only on the left side. You will see in this particular case, the midlines are deviated to the left side, crowding on the lower arch, but a fairly socked in molar and a bicuspid occlusion. She did have an implant in the upper left tooth number 10. And as I look at the panoramic X-ray, you'll notice that the right side jaw joint looks perfectly healthy. The left side is displaced just a little bit posteriorly. At the end of our splint therapy, in this case, because the right side was normal and the left side was a disc displacement with reduction, you will notice that my splint design actually corrected the midline. It brought the lower jaw, more forwards into the midline. Back into the braces, upper left 2, of course, is not bonded. It's an implant. At the end of treatment, she wanted to change that crown because it was done years ago, and she didn't like that. Again, standard mechanics, incorporate bite turbos on the upper ones, light class 2 elastics, and we've tried to finish get the vertical dimension of occlusion, in this case, settled only by means of braces. Midlines are matching. Luckily, again, throughout the treatment, we monitored, there was no pain, there was no discomfort. Same retention protocol. If patients are okay with a fixed retainer, we'll give them a lower 3-3 fixed retainer and an upper stabilization night guard with that ramp. This was a case, a 34-year-old patient. She started complaining of jaw pain during her college life, so which was about 10, 12 years ago, up until in her late 20s. Again, a typical mild class 2 div 2 malocclusion. In this case, she had bilateral disc displacement. So here's your very, very mild class 2. She was missing a lower incisor. That's why the midlines seem off, but they're not. She only has 3 lower incisors. Look at her, condyles. In my opinion, they are posteriorly displaced. They're not in the most natural position. So same protocol, anterior repositioning splint. And then in this case, she had just joined a new job. She did not want braces. She didn't feel like she was. I usually don't use aligners for TMD patients. And she did not want clear brackets either on the anteriors. So she opted for lingual braces. This is called the BIDS lingual system. We are able to use a light elastic to work with, nothing heavy. And so there's a clear button on the upper canines and a metal button on the lower molars for the class 2 elastic. And here is her final bite. Again, aesthetically, not a great result. She was not looking to correct her the little overlapping of the laterals as much as the relief of the jaw joint. Now, this was a tough case. She was young when she had the clicking and popping, and it's been lasting for a long time. So same protocol, end of the session, we give them a fixed retainer. This is the case I wanted to show all of you because there was some interest in aligners. This patient had jaw gets tired in the morning kind of symptoms, which immediately tells me that this is just muscle clenching. And her chief complaint was not TMJ. She had come to us to correct the malocclusion on the lower anteriors, and she wanted aligners. So because she had TMJ symptoms to begin with, I told her that typically I do not do aligners, but if you insist, I'm going to do a little modification in my aligner setup. At any point, if the aligners start bothering your jaw joint more, we will have to pause, and I will have to give you the Aqualizer splint during that time. So here is my Invisalign setup. I'll skip through the panoramic X-ray, but here's the initial setup for the Invisalign. And on the bottom screen where it shows the upper occlusal view, some of you may be familiar with this Invisalign setup where we can use these virtual biturbos. With Invisalign or with patients who are otherwise reporting of TMJ symptoms in the middle of treatment, I will not put the biturbos on the upper ones. I prefer that put them on the upper canines because obviously we are, treating the aesthetics of the upper anteriors. And here was her final result. The bite, of course, improved a little bit. She was happy that her lower crowding got relieved. And we were happy that the TM joint symptoms did not flare up during the treatment. And then the last case, if I may, young female patient, you all may experience this in your clinical practices. The patient starts with orthodontic treatment. Parents start calling you that, oh, doctor, the jaw is starting to click, and you're wondering what happened. And I must have missed, clearly checking for TMJ history because of the age of the patient. She's a young female patient. Why should she have, any TMJ conditions? So very simple case, mild class 2 canine relationship, mild crowding, mild to moderate crowding, if however you want to call that. The jaw joints, when I look at the panoramic X-ray, I do not see major displacement of the condyles. But now that I look carefully, the left condyle shows the beaking, and that's what I missed in my evaluation. And clearly we started with the braces treatment, and the patient started complaining of clicking of the jaw joint. We were in a very light class 2 elastic. It was a parrot elastic from Ormco, which is a 5/16 2-ounce elastic. But because she was complaining of the jaw pain, my immediate go-to is a biturbo on the upper canines, disocclude the posteriors, give away, let go of the elastics for 1 or 2 visits until the patient stops complaining of any clicking or popping. And if we follow the protocols, usually we find out that the clicking and popping slowly starts to disappear. So I wanted to share some cases, primarily patients who come to us asking for TMJ help and how we treat phase 1 and phase 2, and what could happen if a patient insists they want to do aligner treatment, or what could happen if a patient starts to develop clicking and popping in the middle of a treatment. So my goal in learning about TMJ was not to be scared in treating these TMJ patients, and to be well educated for patients who are already in treatment, and to be able to guide them properly. So I hope I'm able to share some of these cases, and I took a few more extra minutes of your time, so my apologies for that. I'm going to stop sharing my screen and see if Dr. Manju has any questions for us.
Thank you, Dr. Abijit. We have a lot of questions. Now I would request Dr. Shreyas, our staff in the department. He will moderate the session for the question and answer sections.
Thank you.
Thank you so much, sir, for the insightful journey on a very mysterious topic. That's why we had the topic named as TMD Demystified. So firstly, I would like to tell all the participants to fill the feedback form so that we can process the certificates. And We have a lot of questions, so I'll be asking a few to you, sir. So you can just probably take a break, you can listen, and then we can start off with the questions one at a time as you wish, sir. So the first is, during the fabrication of the splint, you gave us a complete demo on how the splint has to be done. But if we have to order it from a lab, like we do not have a setup in the clinics here. So if we have to order it from a local dental lab, so what is the splint like? Do we have to go for a hard Essex material or an acrylic splint? If it's an acrylic splint, what is the thickness or the specification is what one of the participants wanted to know, sir.
Yes, so that's a great question because, although we may not have access to
Abijit, unmute yourself.
Oh, I'm not, can you hear me okay? Can you hear me okay?
Yes,
yeah, now.
Okay. So, a lot of clinics in India, of course, may not have access to, the units to fabricate the appliance in your own office. But the tray that I showed, the dental acrylic, is readily available from our supplier. We have all used that in our BIDS days, fabricating, tinkering along with the dentures in Panoramic labs. So you can ask your lab to give you a base splint made of Essex material. I like the 3 millimeter hard soft because the softness of that splint is very comfortable around the teeth for these patients. So hopefully your local lab, can, and I don't have all the entire catalog for the Essex materials with me, but just make sure that you're choosing a material which is easily adapted to the dental acrylic, because there are some Essex material like the retainer material, you cannot, it's thin and it's brittle. So you cannot adhere the dental acrylic to that. So just call your local lab and say, hey, I need about a 2 or a 3 millimeter thickness splint. I used to do them in completely hard splints, but they become too cumbersome for the patient. So I prefer to use the hard soft. Once you get the base splint from the lab, the next steps that I showed you, we can all do them in our offices. And those materials are not very expensive. They are regular acrylics that we use for dentures.
Yes, I think that kind of answers the question. So going to the next question, in a clinical scenario, we do see attrition, like the wear facets as a common clinical scenario. Now, how do we differentiate if the wear facets have happened due to a parafunctional habit like bruxism, or due to something like a traumatic occlusion caused by a class 2 division 2 or something like that? So that is the question, sir. How do we clinically differentiate between these two?
Yes, and good question, Dr. This is, I think, a topic for a different time, because anytime you see wear facets on a teeth, severe bruxism, I am not thinking about dental problems. This now goes back to our training with sleep apnea. Any patients who complain, or the dentists who complain that, you're grinding your teeth, let me give you a night guard, they have all good intentions. But if you're not diagnosing sleep apnea in those patients, or if you're not suggesting that these patients go get themselves checked for sleep apnea, then I think we are doing a disservice. So major severe posterior grinding or wear facets are a primary finding in sleep apnea patients. I'd be more than happy to answer questions via email or send material on that. Now the anterior, lower left lateral incisor or a canine getting worn down, that could be parafunctional habit because of a malocclusion. But severe wear facets on the back teeth, posteriors, that is purely, in my opinion, and from what the research now shows, there is an underlying sleep apnea causing the parafunctional destruction of the dentition.
Definitely, so because sleep apnea itself is a huge topic that we need to address in a different clinical scenario. Going to
the orthopedists, we are very, very apt in treating sleep apnea. So that's definitely a good topic for us.
Right. So in India, it's just picking up now, because here the patients do not want to agree that they don't get sound sleep. It's still a taboo that we need to address.
Yes.
So moving to the next question, sir. Now, if there is a growing patient, let's say they're still in the growing phase and they do present us with some TMD complications and they need some amount of mandibular advancement. Now, would we treat the TMD together, or do we treat the TMD first and then take the growth modulation as a different phase? How do we address that, sir?
I think that again, a good question, and I'm sure there are too many members on our panel here that are listening that can add to this. But um, in my opinion, I would first treat the TMJ condition, the TMD, because if the patient is actively complaining of the TMD, we know that mandibular advancement can be done easily in the growing child, but the parent of that child wants to make sure that we are addressing the concern. Now, in these patients, and if they are really a young growing patient, I've never, I don't want to say never, but very rarely seen a patient complaining of, some kind of a TMJ pain that they cannot live with. It could be most times in that age group patients, it is a local muscle soreness and possibly causing some form of inflammation in the retrodiscal tissue, but it is not going to be a true condition where they're going to need a long-term TMJ management. But hopefully, if they have a class 2 malocclusion, and hopefully we can correct that with a functional appliance.
So in clinical scenarios where you spoke about the disc arthritis, now is that an area of focus for an orthodontist, or do we have to do a higher reference to a surgeon or probably who has better diagnostic centers or something? How do we take about in a clinical scenario, sir?
Yeah, so osteoarthritis, or a degenerative joint disease is the ultimate conditions for TMJ where the patients will land up with severe pain and discomfort. We as orthodontists will not get a referral for that unless, you start to specialize in treating TMJ patients. And now, after 6-7 years, sometimes we'll get active referrals from other dentists to treat TMJ conditions. And that's where we end up with, I've had about 4 or 5 patient referrals with severe osteoarthritis conditions. But that's not something like I shared, that's not something we can treat with phase 1 and phase 2. So whether as orthodontists we have a role in that, I don't want to say we particularly would. We would probably refer it on to, a university setting or somebody who's an oral surgeon who might, do other surgical treatment plans for them. But if you know about TMJ conditions, then you have been able to diagnose the condition, which by itself is a big service to the patient, because some of these patients have unexplained TMJ for years. And you as a provider, are trying to explain to them and educate to them. So that's where our service we can provide, not necessarily as orthodontists, but maybe as dentists or as a dentist who knows TMJ conditions.
Right, sir. So just a personal question, if given an option and finance is not a consideration, and if the TMD patient comes to you with a problem, would you like to treat with fixed mechanotherapy or aligners? What is your take on it?
So if I understand the question, the patient has active TMJ condition?
Yes, sir. Yes, sir.
If the patient has an active TMJ condition, I personally, in my consultations, I'll say, let's treat the TMJ and then let's move on to braces. Most of these are adults. I'll say, we'll use a clear braces on the upper arch and metal on the lower. If they insist on some aesthetic appliance, then I might use a lingual appliance. But as I showed you, I have about maybe 2 patients in aligners that were not in severe pain. They didn't have the disc displacement. They did not have the clicking and the popping, but they just had the jaw being tired kind of a feeling. The jaw being tired always has got to do with the muscle component, not the intramuscular component. So if it's a muscle component and the patients insist that they want aligners, I let them know that at any given point their TM joint starts to flare up, that they give me permission to pause their treatment. So if that's on the consent form and they insist that they want to use aligners, I'm okay to use aligners. And now, of course, as you all know, our aligners offer us the ability to add virtual biturbos on, any of the anterior teeth. So we can incorporate that in these particular patients. But given a choice, I would prefer fixed mechanotherapy.
Great, sir. So in few adult cases, we come across that there is some irreversible changes that we see. There is condylar resorption or the disc resorption that we have already seen. So are they good candidates for orthodontic treatment, or do we defer them and just wait and watch, or how do you tackle such situation, because you have dealt with a lot of adult scenarios?
Yeah, so that's where the first part of the slide presentation today was about diagnosing the condition.
Correct.
And making sure that we listen to the patient. So if there is, if you're saying that there is irreversible damage, what is the irreversible damage? What is the length of that damage? So the first is very important. Can the disc, is it degenerative joint disease? Is it disc displacement? If it is disc displacement, is it a reversible condition, that this displacement with reduction or without reduction? So you go through the flow chart, and if it is a chronic condition without reduction, then phase 1 stabilization splint only. If it's an osteoarthritis, the degenerative joint disease that you're talking about, then stabilization splint on my part as a TMD provider, and then a referral to an oral surgeon or a university setting. But any of the other conditions we can treat, because we now know that if a patient has a TMJ condition, that could be occlusion could be a part of it, then we are the patient is in good hands, because as orthodontists, we have the capability of treating their malocclusions, but as TMJ dentists, we are now able to diagnose the condition and guide the patient into the proper therapy.
Right, sir. I think that makes it clear. One last question, sir. Let's say we do the popsicle test and we get to know that the muscle is the cause and not the joint. So how do we take that line of treatment?
Perfect. So, patients don't know what is TMJ pain. And remember, right, we as professionals, we say TMD, whereas patients always refer to as TMJ. Well, so here is our opportunity for education. First thing we tell them is, number one thing you have to be aware of is this is not a true TMJ condition, or not a true intracapsular condition. This is a muscle condition, right? So what is a muscle condition from? Constant clenching and nighttime grinding. So what is a constant clenching from? Do you have any stressful events during the daytime that, you are a type A personality constantly clenching their teeth? Or do you have grinding at nighttime from possibly sleep apnea symptoms, right? So here I'm trying to make a differential diagnosis. If it's daytime clenching, then I'll let them know, we educate the patient about the ideal position of your teeth and your jaws. So the classic line I use is lips together, teeth apart. So lips together, teeth apart, or, like we've done in dental school when we're trying to, get the patients to say S, and then, figure out, the freeway space. But patients don't know these. So these type A personality patients are constantly clenching. Their teeth are always together, right? So we have to educate them that this is not, your teeth don't have to touch each other all the time. Lips together, teeth apart is what you have to focus throughout the day. And if you need, then we can give you a lower mandibular stabilization splint, which I call it a trainer splint, because I don't want the patients, I don't want the patients to feel that this is a crutch. I want them to be educated that what is their daytime symptoms coming from, and then the other supportive therapy, the moist heat, if they want massage therapy, physical therapy, all of these things are supportive treatments. But you have been able to diagnose, is it from daytime or is it from nighttime? If it's a nighttime, the patient cannot control it, then I'll give them a nighttime stabilization splint.
Right, sir. One last question. I know it's almost late into the night for you. How does the laser help? How does the laser help? So you showed me that you carry a biolaser. So how does laser help? So if you can just throw some light on it, please.
Absolutely. So it's a little bit more aggressive muscle relaxation therapy, right? Instead of just moist heat. Now it is something that we as providers can control in our offices, as opposed to telling the patients. We have all experienced this. You tell the patients, you give them a set of instructions, and by the time you're finished with the last instruction, they have forgotten the first instruction, right? So as you know, if the patients go back home and they're not going to follow your instructions, they're never going to get the relief that they were looking for. So in that situation, I have the biologist in my office, and I let them know if they want, they could certainly use the help of the biologist unit. So there's no secret there. It's a laser pain therapy, just to reduce the inflammation of the muscles and relax the muscles. That's all.
So I'll be handing over to Manjunath, sir. Thank you so much. And that was a great interactive session. End
You're
of the
welcome.
day, having so much energy, it's incredible, sir. Thank you so much, sir. I'll just hand over to Manjunath, sir.
Thank you very much.
Okay, thank you, Dr. Abijit.
Thank you, Dr.
I see that you are doing a presentation. You're standing there, I believe.
I am. I had to, one of our good friends yesterday gave me the feedback that my bald head was too much for the camera. So he told me to and stand in a different angle. So I thought I'll stand today and see if the camera does not capture
and also because your guru is here.
Yeah. Yes.
Yes.
Of course.
He's not sir, Jaydev sir, do you want to ask anything, sir?
No. Abijit has answered every question very well.
Thank you, sir. Definitely been a pleasure to see you after so long and to be able to interact.
Yes, it's mutual.
Blessings.
Okay. I would I would take this opportunity to thank all the participants who are here till the end moment. We can see how much Abijit has. They are still waiting for you to speak, I believe, answer some more questions. But Dr. Abijit, can I give them your email ID if they have any queries to ask?
Definitely. Yeah, please feel free. I may be slow in responding to the email, but I'll try my best to answer most of the questions, if not all.
Okay. Thank you, Jaydev sir. Thank you, Dr. Abijit. And I would like to thank all the iOS office bearers, the EC members who are all attending. There are senior professors who are also attending here. So I would like to thank all of them. And I would like to thank the BIDS management and our principal, Dr. Vinaya Pai, for their constant encouragement and support in conducting this kind of webinars, which will help the students and the practitioners. Then I would like to thank my department staff, Dr. Shreyas and Dr. Harish, and all my dear postgraduate students who took out the time and efforts to make this make this program run smoothly. And I would like to again thank the iOS for office bearers for providing us this platform to conduct this webinar. And Dr. Abijit, when we talked to him about which topic would you talk about, he had given us a list of topics. He is an expert in insignia and airway problems and Damon philosophy. And also probably he can also take a webinar on how to fly an aircraft also, I believe now. He's licensed to fly an aircraft also. So it was very interesting. And I hope to have more webinars to you from your end to all of us to enlighten all of us.
It's been a pleasure, Dr. Manju.
Yes,
definitely, it is great to interact with all our iOS members. I certainly miss this interaction, for so many years. So thank you again for the opportunity and wishing everybody the best for the for their orthodontic careers and whatever their next endeavors that they may choose. Again, Dr. Jaydev sir, thank you so much for being here, and to all the iOS members as well as the team from BIDS. It's been a pleasure.
Okay. Thank you, Dr. Abijit. Good night for now. We can let you go back to your wife. Okay.
Thank you.
Yeah.
Enjoy the rest of the day. Once again,
Thank you, sir. Good night.